So good morning and good afternoon. My name is Sean Moore. I'm the manager of special projects and initiatives at the Community Anti-Drug Coalitions of America. Please do let me know if my audio is not good quality, and we'll just go ahead and kick it right over to Christina. I have a fairly weak connection at the moment. But I want to thank everybody for joining us today for SBIRT Skills Development. This is the third in a series of webinars that we're doing on SBIRT, or screening, brief intervention, and referral to treatment. We're following up on a sort of mile-high overview of SBIRT, and then a second webinar that delved more into what it looked like to implement SBIRT in different situations. And now we're going to be doing sort of a deeper dive into the brief intervention skills related to SBIRT. And so I'm really excited for this webinar. I'm glad everyone could join. Christina, could you go ahead and advance the slide? We're doing this webinar as part of the Opioid Response Network, and that is a technical assistance grant that has been set up by SAMHSA. And that is to provide technical assistance, educational resources to people working on the opioid epidemic in local areas. We're providing technical assistance across prevention, treatment, and recovery of opioid use disorder, and of course, emphasizing using evidence-based practices in our technical assistance. We are a request-based platform, so we'll probably circle back to this towards the end of the webinar, but opioidresponsenetwork.org. Please visit that website, look at some of the information available there, some of the partners that are on this project. We really rely on receiving a request from you so that we can understand what the need is, where you are living, and with the work that you're doing. Across the country, we have teams set up led by technology transfer specialists from the addiction technology transfer centers, a great team of prevention consultants, recovery consultants, and treatment providers with multiple years experience in prescribing medication for addiction. We could probably go ahead and advance the slide. So again, there's that website, opioidresponsenetwork.org. Our lead organization on this is the American Academy of Addiction Psychiatry, so you can always reach them. Some excellent program managers on their team, orn@AAAP.org. Someone always answers that phone, so please do feel free to give that a ring. We really hope to provide you the best technical assistance that we can. Of course, as a federal project, we need to say that the views expressed in this webinar are those of Christina Boyd, myself. They do not necessarily reflect the views of the US government, of HHS, or of SAMHSA. So again, our goal with this project is to build on what you are doing on the ground. We need to understand that, and then we can hopefully identify some gaps, but we're not there to redo work that you and your teams are doing at the local level. We're here to enhance that and help you network with other resources that are available already. And you could go ahead and advance that slide too, Christina. So for the webinar today, there is a raise hand function, but I don't think we'll need that today. Do feel free to chat. You can chat to either all panelists, which would be myself and Christina. You could chat to all attendees. It looks like there's going to be over 100 participants in today's webinar. So you can use the chat function as you need to, and anything you would like to have addressed, please do use the Q&A box. We might not answer that immediately during the course of the webinar, but we'll return to questions and answers towards the end of the session, and we really value that as a way to address what it is you're thinking about, what it is you're facing, how could we best address your needs. I'll come back with a PDF of the slideshow that you're seeing right now after the end of the webinar. And we'll also have a link to the YouTube. We're going to post this on CADCA's YouTube channel. And so you'll see there all of the different webinars we've done with the Opioid Response Network. If you have any questions, anything about upcoming webinars, do feel free to email me, Sean Moore, at cadca.org. Our speaker today is Christina Boyd. She is a clinical social worker and an addictions counselor who has worked with the behavioral health field for over 22 years. She's currently the Western Kansas MSW Program Director for the University of Kansas School of Social Welfare, and she's the CEO of the behavioral health consulting company Hope and Wellness Resources. She's an experienced SBIRT trainer and has provided live and virtual presentations on the implementation of SBIRT into medical settings and throughout the country. She does reside in Western Kansas, and she's passionate about equity and health resources in rural areas. So without further ado, I do want to introduce everybody to Christina.
All right, thank you so much, Sean, and welcome everyone, and glad you could join us today. As Sean said, we have quite a few people here on today, but we definitely want to hear from you. So hopefully, if you do have questions, please feel free to ask those as we go along, or any comments, you can always put those in the chat. Just a quick agenda for today. We're going to do just a really short overview. Hopefully folks were able to join from some of the earlier webinars to see or to gain information about just a general overview of SBIRT. If not, you can go back and watch those recordings, and hopefully that would be helpful. Today we're going to really focus on that brief intervention, which truly is kind of the meat of these services. Screening is a piece. That brief intervention is so crucial, and having some good skills support, ongoing evaluation of that process is often helpful for agencies or communities that are implementing SBIRT into their services. We will break that down into 4 steps. Having some structure around that has been very helpful for individuals who maybe aren't as accustomed to having these types of conversations or aren't as familiar with motivational interviewing, which really is utilized as a spirit of that in this brief intervention as it's presented. We'll also talk about referrals. This is another area where I think we're really starting to break down some of those silos of prevention, treatment, recovery. We kind of really need pieces or players from all of those sectors when it comes to really implementing SBIRT successfully. And so we'll talk about that referral process. We'll touch on what a warm handoff is, and again, how communities can help to support all the different practices and skills that are used in this brief intervention process. We'll address some of the referral issues. I think sometimes that also brings up some interesting challenges in communities. And so we'll address some of those challenges today, and then we'll have a little bit of time at the end, hopefully, for some questions. So let's get going. So if you've been on other webinars, this is going to look a little familiar, but I think it's really important as we start to implement any new process, really, but especially around SBIRT. We may be having conversations that we've not typically had in our settings or in our communities around substance use, around risky use, those types of things, which is really at the basis of what SBIRT is designed to address. So why we need to be using these services is always a great place to start. I think in communities, in agencies with practitioners, clinicians who are actually going to be providing these services, there may be a general knowledge that substance use is important or that we need to talk about it, but really getting into why this is so important now, maybe why we're hearing so much about SBIRT, about the opioid crisis, those kinds of things. I think it's a great place to start in any of our conversations. We can move on to the nuts and bolts of the how, and we always want to be careful we're not skipping the why. So just as a general kind of idea out there, that's a great place to start any of these conversations. Many of you are probably aware of this. These numbers continue to rise, although this year we did see a little plateau in certain age groups, which is very promising. But in 2017, on average, we were seeing about 130 Americans die every day as a result of an opioid overdose. So definitely we've seen an increase in the use. the impact of that particular substance. I know in communities that I'm working with currently, they talk about opioids are definitely an issue we're wanting to address, as well as other substances that may be prominent. So just thinking about where you live, there may be other substances that are on the rise or that are really prominent in use. Some of those might include amphetamines. We're starting to see a resurgence of that, an increase in use in that, as well as alcohol and other substances. So, and then also depending on where we live and the availability as regards to legalization, we're also seeing an increase in marijuana use. And particularly of concern is in states that have legalized an increase in adolescent use. Colorado has some really, really interesting statistics and some white papers they've put out in regards to their recent legalization of marijuana, for example, and how that has affected youth and the increase in their use. All of this relates to, again, community prevention efforts in recognizing kind of what areas or what substances we need to be focused on. As I said earlier, SBIRT, it's all about prevention. For those that aren't as familiar, I'll just very quickly kind of give a very quick overview here on screening. The idea with screening here is that we're doing this universally. It's not just pick and choose who we give a screen to, but really this becomes universal. It becomes part of the practice that we do a pre-screen or universal screen with everyone. And that again has been utilized community-based, agency-wide, hospitals, for example, universities, or even schools are getting into delivering screens and then doing some education intervention around that. With that universal screen, the need to have a targeted screen. If someone tests positive on that pre-screen, a more in-depth screen is done. Now, again, with these screens, we're not going to go into that a lot today. We're going to be focused on the brief intervention. But just keeping in mind, again, these are brief. These are 6 to 10 questions in most cases. So this is something that can be done very quickly. The scoring of these is very straightforward, not a lot of subjective, not a lot of clinical knowledge or licensure needed in most cases, depending on what your regs are or in your state around that. But in most cases, individuals can be trained to deliver the screen, score that, and then, you know, an intervention is based on the scores of those. With that brief intervention, what we're going to talk about today is how do we help individuals understand their substance use and then really relating that to their health impact. So we found that individuals maybe are a little more receptive, don't get maybe as defensive if we relate their substance use to their health. So this is really getting away from this being a moral issue or whether they should or shouldn't or legal or not. It's really just about how it impacts their health. And again, very straightforward information, some good resources out there available, and I'll talk about those today a little later. We also, as part of this brief intervention, want to be looking at motivation. You know, again, the why, again here, that sounds familiar, is very, very important in helping people to make change, because we know, even from our own experiences, change is hard, right? If we've tried to make changes in the past, sometimes it takes some efforts and some real mindful practice to stay motivated towards that change. Here at the end of the year, I always like to remind everyone, you know, we oftentimes have goals coming up around the first of the year around health or exercise or whatever the case may be, and just recognizing how hard that can be to make that change or to stick with it. And so that sometimes helps in making that relation to other people's change processes and how difficult that can be. So we'll address this a little more in depth here in a second. And then also, it's important to recognize that with those brief interventions, the screening and the brief intervention, we may identify individuals who are using beyond a risky or harmful, but really in that severe category that may need or benefit from a referral on to more specialized treatment. A conversation or two, a brief intervention may not be enough. And so having referral mechanisms in place, and this is where, again, I think coalitions, communities can really be helpful. Actually along in all of these areas, but in that referral aspect, in connecting communities and identifying, again, maybe gaps, advocacy opportunities, that sort of thing, so that we can help individuals who are showing signs of a substance use disorder access that specialty care that they so desperately need. So we'll get into the brief intervention and the referral to treatment here today. So keeping in mind, SBIRT does target the 20% of the U.S. population that uses substances at a risky or harmful level. This is really where research has shown the most impact, the most positive outcomes for doing a brief intervention is for these individuals. Now, there's a certain percentage, about 5%, that are going to fall in that risky category. We're still going to use a brief intervention, but the purpose of that intervention is going to be slightly changed. We want to, at that point, be motivating those individuals to take that referral or to show up for that referral, to engage in that next step of treatment. So these skills are really, really crucial. The other thing I would say, though, about them that I've found and that others have found is that these skills are very transferable. As we learn these skills, or as individuals are trained on them to motivate individuals towards change, we found that change is change, and that regardless of what someone may be looking to change, whether it's reduction or abstinence from use of substances or other hard or difficult changes, those skills to help motivate and to support those individuals really are similar. And so just keeping that in mind too, within agencies, communities looking to adopt some of this, that the efforts and the resources put into developing these skills, that's really money well spent and time well spent, as we see that these skills are, again, highly transferable. So we'll kind of delve into that brief negotiated interview just to give an idea of what that looks like, how it came about. So it was developed for use in emergency rooms. It really relies heavily on the spirit and skills from motivational interviewing. So Millers and Rolnack, they were researchers that were looking at how do we intervene with, at that point in time, individuals who were dealing with the alcohol use disorder. And they found that these techniques were very helpful, and they seem to be to have really good outcomes. And so we've started to look at motivational interviewing in that realm, expanded to other substance use disorders, and then subsequently in recent years we've seen that really has become an evidence-based practice for a lot of behavioral health overall. So not just substance use disorders, but other mental illness and other diagnoses as well. It's very patient-centered, which is really where we're moving towards in treatment. That our approaches are collaborative. The conversation is very goal-directed and uses the patient's own, or the client or participant's own, motivation to change. So this is a little different than maybe having, here's the reasons why I think you should make this change, where people tend to, again, kind of push back or get a little ambivalent about making that change. It really is allowing people, or evoking from individuals, what is their motivation for making this change, which may include things that we never even knew about, or were privy to that knowledge if we aren't asking those questions in that way. It also recognizes patients, participants, clients' conflicting feelings about a particular change. So as I mentioned earlier, if you can think of your own change process of maybe eating healthier, working out, whatever it was, that we're looking to do here in the new year, thinking about how it's very easy to say, yeah, I know I need to eat healthier, but those buts come in, right? The but, it's really, really hard. We might have childcare issues, or we just can't seem to get motivated to get up before work to make it to the gym. So again, recognizing that and acknowledging that is helpful in this process. And so that's part of the steps of the brief negotiated interview. So here are those steps outlined. Again, keeping in mind that these are suggestive in nature, that we follow these steps to give us some structure. Again, help individuals who maybe not had these conversations in this way feel more comfortable. You can find these steps outlined in a lot of resources out there that actually give particular example statements and questions to follow each step, so that we kind of have a guide. Sometimes if we just have an overall general conversation and we don't have some of these steps, we can get off track. We might have a limited amount of time, so this kind of keeps us moving forward. Hopefully we can get to that negotiate plan before we, if this is done in a 10-minute session or 15-minute time frame, we really can move through these steps. So first off, we want to raise this subject, talk about it. Again, we're going to introduce it in a way that hopefully individuals are willing or acceptive of having that conversation. We want to provide feedback, and this includes giving concrete information, correct information about what substances an individual may be taking into their body and how that's affecting their body. So again, in past webinars, we talked about the amount of misinformation out there, particularly around, marijuana and other substances where, legalization and other aspects gets debated. But really, you can type in marijuana right now into the Google, search engine, and you can find a lot of information. Now, whether that information is validated and evidence-based, that's a whole nother question, right? So we want to provide very good evidence-based feedback, resources, information to individuals so they can make an informed decision about what substances they're putting in their body and at what frequency. So really, again, keeping this in the realm of health. We then want to move into enhancing motivation. Now, again, this is not just pushing people, convincing them that this change is awesome for them, but really asking them, why would this be important for you to make this change? How do you think you'll do it? What are the 3 best reasons why this might be a good idea for you? Those are the types of questions that we're going to use to really enhance that motivation towards them figuring out what is their why. What is the reason they would make this really difficult change or or make this big decision to make a change in their life? So again, whether that's reducing use, abstaining from use, and also maybe taking a referral or taking a referral on to more intensive treatment. So that all of that kind of in that step 3 is addressed. And then in step 4, we always want to negotiate a plan. What's the next step? What are you willing? What do you think you'll do? Let's write it down. Research shows that if we talk about a goal, we're more likely to adhere to it or to achieve it. And then if we want to take that a step further, if we write it down, we're even more likely to do it. So just keeping in mind there that we can follow. Again, these are steps that have been established and recommended for quite a while now, and researched and shown to be effective. So one thing I like to point out just in that brief intervention, it really is about the forest, not the trees. Sometimes we get really caught up in, okay, I got to go to step 1, then step 2, then step 3. Really keeping in mind the spirit of this, and that we're really just trying to motivate. We're trying to, help individuals see this by opening up the conversation in and of itself and being met with non-judge. If we don't make it through all the steps or people kind of jump around, it's okay to follow them. We don't want to lose sight of what the purpose of this is. So just kind of keeping that in mind. We don't have to say everything perfect. It really is about the overall message, and again, helping and assisting people to feel supported in making some change in their life. I had a colleague that I did some trainings with, and she actually got to do some training with Dr. Miller, so of Miller's and Rolnick, who developed this approach of motivational interviewing. And she told this story, and I just love it. They were doing a case scenario one day and going through role play, and Dr. Miller was providing, this intervention. And at the end, someone said, "Hey, Dr. Miller, do you ever get done with a session and think, man, I wish I would have said that differently or I worded that in a different way?" And he said, "Yeah, every time." And so I love that story because I think it really highlights that we don't have to have the perfect words or say everything exactly right. It really is about recognizing that we can be there to open up the conversation, talk about a few things. Again, feel competent, and we want to have some competency, some training in this before we go handing out screens. And we can recognize that really even the person who developed this, there's always room for improvement. So continuing in that idea that we don't have to do this perfect, but we just want to be able to support people in that change process. So I thought it might be helpful. This is about a 5-minute video here to see what this might look like. So for individuals who have not been as familiar with brief intervention, motivational interviewing, to kind of see it, how it actually looks, if we were to administer this. Now this is an example. This is taken from SBIRT, Oregon. They have some wonderful videos, some really good resources out there if you want to take a look at this. And again, a lot of the videos are on YouTube. I'm going to switch this over here so we can take a look at this. And again, it's about 5 minutes long.
Jacob is a 14-year-old boy presenting for a sports physical exam. He completed the CRAFT screening tool and answered yes to the relax question. The physician has completed the physical exam.
So Jacob, everything looks very normal on your physical exam. Do you have any questions for me?
No.
Okay. I see that you filled out our alcohol and drug questionnaire. Is it okay if we go through this together?
Sure.
Okay. What we talk about is confidential. I only tell your parents about what we say if you give your permission or if I become worried about a danger to you or to someone else. Does that make sense?
Yeah.
Okay. So let's take a look. So I see that you have marked that you sometimes use alcohol and that you have used alcohol to relax, feel better about yourself, or fit in. Do you mind telling me a little bit more about your alcohol use?
It's not a big deal. Sometimes with my friends, we'll drink a few beers and when we're hanging out or when we're at a party, and sometimes rum and cokes.
Okay, so how many do you usually have at a time?
3 or 4 probably. I don't keep track.
Okay. And how often?
Probably about once or twice a month.
Okay. So you drink with friends, sort of 3 or 4 beers or mixed drinks 1 or 2 times a month. How long have you been doing that?
Probably since last October.
Okay. So for about 6 months. I'm curious, what do you like about drinking alcohol?
What do I like about it?
Yeah.
I don't know. It's just fun to drink with my friends. Like when we're at a party at someone else's house and we're drinking with other people that we don't know. It tastes good.
Okay. So it sounds like you feel relaxed and have fun when you're drinking with friends and you like the taste.
Mm-hmm.
Okay. I'm also curious, are there any parts about your alcohol use that you don't like?
I don't like when I get sick in the mornings because of hangovers and when I start throwing up, and I don't like that.
Have you ever experienced a blackout, like when you've been drinking and you wake up and you don't remember what happened?
No, but that happened to someone I know, though.
Okay. And have you had any problems related to your drinking alcohol, like at home or school or somewhere else?
One time I missed first period at school because I had a hangover and I was late getting up. And Mom got mad at me because I wouldn't get out of bed, and she said she knew I had a hangover.
Have you told your mother that you drink with your friends?
No, but I got grounded for 2 weeks after that.
So more negative things about your drinking, like getting into trouble with your mom and missing a class at school when you had a hangover?
Yeah, but I only missed school once.
Okay. I see on the questionnaire that you have not ridden in a car with someone who's been drinking, and you haven't driven a car after you've been drinking. Is that correct?
Yeah.
That's great, and I hope you continue to avoid those things. As your doctor, I want you to know that I'm concerned about your drinking. When teens drink, things can go wrong, like injuring yourself. Even when you don't drink to excess, though, your brain is still developing and is very sensitive to the effects of alcohol.
Okay.
That's why I recommend that all my adolescent patients not drink at all. So if you were to think today about how ready you feel to stop drinking alcohol on a scale of 0 to 10, with 0 not being ready at all and 10 feeling very ready, what number would you pick?
Probably a 5.
A 5. So I'm curious, why didn't you pick a lower number like a 2 or a 3 that would mean you're only a little bit ready to stop drinking?
Well, I guess I'm just tired of getting in trouble.
Okay. What could you do to avoid getting into trouble?
Not drink.
Have you ever tried not drinking or stopping drinking?
No, not really.
What some people your age do is try stopping drinking for a period of time just to see what that feels like.
I could probably do that.
So how long do you think you could go without drinking?
I don't know.
Do you think you could go 2 months without drinking?
Yeah, probably.
What things would make it easier for you to not drink?
I could probably drink something else when my friends start drinking, like just Coke.
Anything else to make things easier for you?
I could probably hang out with some of my friends who don't drink. We're inviting them to parties and having fun, because not everyone drinks at parties.
Okay. Is there anybody in your life that you can talk to about this who'll give you some support for not drinking?
Yeah, my friends who don't drink would probably be happy that I'm not drinking either, and they'd support me.
Great. So you've come up with some reasons to stop drinking, like having hangovers and throwing up and getting into trouble. And you've developed some strategies to try to not drink, like spending more time with friends who don't drink or having non-alcoholic drinks when people around you are drinking alcohol. I think that's a great plan. I'm really proud of you for giving this a try. How about if I have you make an appointment for 2 months from now, and then I'll see you back and we can see how things are going.
Okay.
Okay, so usually when I show this video and we kind of talk about it, would ask, kind of things that stood out. And I can tell you some common things within this video that are highlighted here. It's not just the steps, but she made a point at the beginning to ask permission. That's really important in this process. It kind of helps to bring that power differential down to where we're having a conversation with someone. She used some real concrete skills in there about readiness ruler when she was asking the score and then asking why not lower. That really helps individuals to present their side of why they want to change and giving their reasons why they should do that. She also did the pros and cons, and I thought the actor in this did a great job when she said, "What do you like about drinking?" And he said, "What do I like about drinking?" Like no one's probably ever asked him that before. So, I always like to share, hopefully everyone's seated at this moment. I'm going to share some really shocking revelation to you. But people take in substances for a reason. I know, shocking, right? So there's a reason people will use substances, and it's okay to talk about it because that can also lead us to understand maybe again their motivation. Is it because it helps them? Is it for euphoria, which is a very common reason, or is it to alleviate anxiety? And then we need to, maybe that's something else that needs to be addressed. So again, throughout this film, this is just one. There are many out there that kind of highlight what this might look like. So as we're supporting SBIRT implementation in our communities, looking at these types of videos, talking about the skills needed, are there gaps in training, those kinds of things are all things that coalitions and communities can do, and I'll kind of go into this in each section here to highlight that. So in that first step, you might have noticed she explained her role, she asked permission, she reviewed the pattern, she asked about in his own words, his use, and really seeking to understand. I think this is a really important piece of this, understanding the person's perspective, not making assumptions, not assuming everyone's the same as far as their reasons for use, all of that. Can really, again, create an environment or a culture in that setting to open up that conversation, and people can feel more comfortable being honest in those settings. So sustained talk. So that's a key component of motivational interviewing, is we want to kind of sail through some of the reasons people talk about that they want to keep using or that they are using. In that is a concept of ambivalence, and I mentioned this earlier, and this idea of change talk being, I really want to start exercising because, I want to get healthy, and the sustained talk is, I just hate going to the gym. So, we have the change talk of making a change, and then we have the sustained talk of why we're probably going to keep doing what we're doing. And that ambivalence falls right in the middle. And so as we explore that ambivalence with individuals, it can sometimes help to highlight what is their motivation, what are some things that they can do to increase that change talk, which is what we're shooting for. So what can we do, or what could you do? So coalitions and communities can really work towards addressing stigma and raising awareness in their communities. So for this first one, as we're raising the subject, the more that we've addressed stigma, the more that we've raised awareness about these issues in our community as a whole, really the more likely individuals within those communities are going to share these types of things. Because again, these are stigmatized subjects. There's reasons people don't disclose this, right? And so I've talked with the individual like up in Massachusetts. They're now doing universal screening in their public schools, which is amazing. But when I talked with this individual, she shared that one of the very first things they did was really looked at awareness. They did a whole year campaign on awareness and addressing stigma before they ever encouraged individuals to start handing out those screens. So once again, I think as coalitions work together, what campaigns are out there? What are you doing to talk about underage drinking? What are you doing and you may be doing some of that already. How could that be involved in a project involving agencies or facilities that are thinking about implementing SBIRT? Sometimes we can kind of come at it with everyone kind of on the same page, working towards the same goal here, and we can get some synergy in those projects, and when we include community partners in them. Step 2, in providing feedback. Again, there's low risk guidelines out there. We talked about those the last couple of webinars. We're not going to go deep into that today, but definitely some consistency in the standards so that we can have a conversation about what low risk drinking is. Again, we explore that connection to health, and then talk about the concerns that the patient or the participant or client has, using some education materials and really focusing that conversation. So these are examples. I'll show you where to find these here at the end, but these are some really great, I call them gingerbread people, have some great information about just how substances affect the body. This is not saying someone's morally corrupt by using these. It's just straightforward information about here's a substance here, it's affecting your body, and what do you think about that? The nice thing is that these are available in multiple languages. They're free. You can download them, print them, pass them out, and there's no charge for that. They're in the public domain. So I'll show you where to find these later. I think they're very helpful. So what can you do? So for this step, I think coalitions can really work to get handouts and information readily available. So, we can help to have some of these printed. I'm using those as an example. There are many out there that are very good. Sometimes regions will also develop their own, which it can be an important project for a coalition or other groups working towards assisting SBIRT adoption. And so being able to print these out, having them available, also sharing them digitally. I think our social media campaigns can have a lot of power and impact. So these are things like these infograms and different handouts that can be distributed not only physically on paper, but really looking at how can they be supported in our social media campaigns that we're putting together. Again, is this something we could develop, have kind of in a nice format so that it's easy then to get out to community partners and others to really distribute on a wider basis. So just thinking about those things. We're starting to see more of that. I've seen that with SAMHSA, some other kind of federal level agencies are, when they put together campaigns, they're really looking at how the impact of that social media out there. So whether that's Facebook, Instagram, those kinds of channels, how can we take this information and really get it to the people that need it? And primarily, therefore, talking about younger generations, adolescents, their use of social media is, astronomical. And so, what kind of information are they getting out there, and what are they most likely to use? How are we going to reach them? This really gets to, I think, meeting them where they're at. We may or may not agree with whether all that technology is great. However, if we are going to reach a certain population, that may make sense to do that. Okay, so step 3, as we look to enhance motivation, in this step for individuals who are providing that brief intervention, they're going to be talking about the health connection, exploring the readiness to change, maybe again asking about the pros and cons, those are some of the skills used in that, but really looking at that motivation and how do we motivate people towards change. So here, I think coalitions and communities can help in this with coordinating trainings to really help those that are providing these services the skills and support they need. It's so crucial, I think, for individuals not to just go to one training and then start handing out screens. I think it's very important, and what has been seen to be very effective is to have ongoing support for those individuals, because we may run across needing to update those skills or to help support, practice those skills within our agencies, within our service delivery. And so really helping to coordinate those trainings. I found that an interesting aspect of this too, is that we are seeing a lot of TA support, training support, funding coming out. And what I've also seen is sometimes one agency in a community will get some funding and they'll want to have a training, and really trying to coordinate that. So again, we're maximizing that funding dollars, so that if we could have one training and have 5 different agencies there, so that we could then maybe pool those resources to provide that ongoing support, which is really needed. So really, again, maybe being the center of, how can we, if we're all kind of moving towards these initiatives, really maximize our resources when it comes to training those that are going to be providing these services. I think that can be an invaluable piece of this. I know in our state, even, we've started an SBIRT work group so that we can help in this aspect to really try to coordinate, to try to let people know, get the word out there. If there's trainings, funding, resources available, how can we maximize that within our state? So sometimes work groups, coalitions can really be helpful with this. In that next step, negotiating a plan, this is really, talking about a menu of choices, recommending, or not necessarily, maybe recommending, but also just being encouraging individuals to make a plan to either cut back their use, to stop their use, and or accept a referral on. So in this aspect, I think it's important to remember that there are many paths to recovery. So it can be as simple as just doing some education along that spectrum to, someone possibly needing inpatient treatment, and figuring out where, not only where is the individual at, where are they at, where can we meet them where they're at, what are they ready to access, but also what resources are out there along those lines. So when we get into referring to treatment, a strong referral is really, really important. We want to make sure that we've supported that person as much as possible to, again, walk through the door for that initial contact. So 3 strategies to make that strong referral. We want to use a brief intervention. Again, we're using that brief intervention for a lot of different reasons in this set of services. We want to help to build the individual's confidence and willingness to go. We want to prepare them for that referral. And then we want to conduct what's considered a warm handoff when possible. And I will explain what that is for individuals who aren't familiar. So in the aspect of being prepared to make a referral, we want to make sure that agencies within our community are aware of other resources, you know, again, those partnerships that are available. Who do you call? What forms need to be filled out? Who from the team can make the appointment? Making sure we have up-to-date rosters. This is an aspect, I think, again, that coalitions, communities can really help foster a good referral system. Some states, again, familiar with the state of Kansas where I reside. We've started it's an online referral system. It's called DAISY, where individuals within communities can make referrals. Referral agencies are listed. There's releases in place, so there can be this continuity of care, and we can continue to have good communication, those sorts of things. So there's a lot of aspects of that, but something simple as having a roster in our agency, maybe that's something a coalition, or I'm sorry, in our community, that's something a coalition can maybe help with to keep that up to date. Sometimes agencies come and go, things change, you know, what kind of insurance is taken. Those really important pieces of that can be very helpful to have a resource for that within our communities. Now, SAMHSA at the national level, they do keep a treatment facility locator. So this is something that we can look to help on a federal level. So we can definitely access that as well. And that may be a resource that we can share within our community around that. So again, we can work towards coalitions, I really think, can hold a strong key to connecting resources within our communities. Who is doing SBIRT? Maybe that's another aspect. We can connect those community partners together if they're trying to support training, implementation, you know, anything along those lines. Then we want to keep them talking and together. Okay, so moving forward, another aspect of this is that, you know, the MAP provider, so medically assisted treatment, is very, very important, especially when we're providing support around those making changes around their opioid use. So this is an area where, again, trainings could be offered in communities, support for physicians to become MAP providers is another aspect of what coalitions could be doing. So I mentioned warm handoffs. Just to explain what that is, that's when a clinician directly introduces the patient, client, or participant to the treatment provider at the time, in real time. So that works great if we have the ability for very integrated, and maybe someone's been seen and we have behavioral health consultants right there within that agency. That works great. Sometimes that's not necessarily feasible where we're at that particular moment in our service delivery. And so I think there are ways to make that as warm as possible, maybe using televideo, even a phone call. People are more likely to follow up on a referral if they've had some sort of contact with the original provider. So I think, again, evidence strongly indicates that warm handoffs are dramatically more successful than passive referrals. So we want to just establish that initial contact. So could we do that? If they're not in the same building, are there other creative ways we can make that happen? Because ultimately we want to convey the trust and rapport that someone's already shared with the initial provider when they were receiving these SBIRT services. We want to kind of hand that off to the next provider. So these are all important aspects. Again, a warm handoff, if possible, is going to be our best way to do that. So again, in summary, we want to use that brief intervention to help individuals identify their own motivation to accept a referral. We want to clarify and make that referral process as streamlined as possible, and work towards a warm handoff if we can. And another piece just want to mention briefly is follow-up. We definitely want to have some sort of follow-up. If it's important enough to bring up and to talk about, we want to come back to it, and we want to address it if we can. Because we never know, right? We never know when we might plant a seed. Maybe somebody is not as willing or able in a certain situation to take a referral or to access care. If we've opened that conversation in a non-judgmental setting, providing a good conversation where they feel heard, they're more likely then to keep that door open and to come back. And then we have the opportunity to maybe motivate and help connect them in the future. So keeping that in mind. Some resources here, and again, this will be sent out in a PDF form. You can click on these. I mentioned the individual, what I call the gingerbread people. That site is listed on here, the www.sbirt.care. You can find those listed there, as well as a lot of other resources around training and other aspects of care. SBIRT, SAMHSA SBIRT, SBIRT Oregon, IRETA. These are just a few. There are also excellent ones out there, others available. Just these are some that I use quite frequently and find very helpful. Another resource out there, and I mentioned this last week, but that TAP 33, SAMHSA has done a great job of putting these tips and taps to get together. What I love about them is they're free. So you can access those. You can just type in SAMHSA TAP 33. It'll bring that up in a search engine. And it really does give a lot of lessons learned. There have been several cohorts over the past decade or so that have been given sizable grants around implementation of SBIRT, and they've taken a lot of that information back from those grantees and compiled it into one really nice publication. So I would recommend, and again, this might be something that coalitions get copies of. A lot of times it's not in print because SAMHSA is not printing all the documents that they used to, but it is always available for digital download. And what I have seen some agencies or some projects do is go ahead and print this out, get them bound nicely, and then distribute those to partners or participants in these either in the community, in agencies that are implementing that sort of thing. So again, I think coalitions, communities can help in these processes by providing some of these resources, or if they have some funding to do that, to make that available. This is that particular site, just so you can see it. This is what it looks like, and you can see there it has clinician tools, patient education. Those handouts that I showed earlier under patient education, there's also a free training. It's a 3.5-hour training that individuals, it's put through the UMKC School of Nursing, in which a training you can go on. It's online through Healthy Knowledge. You can go in and it doesn't cost anything. And so I definitely recommend that as a free resource to agencies. There's also, SAMHSA just put out, or actually, I'm sorry, not SAMHSA, National Council for Behavioral Health put out a new packet that's really focused on adolescent screening. This comes, it's called Why SBIRT, and you can download it at that site. It's interesting to me that they've now moved, they recommend screening to start at age 9. So definitely earlier and earlier in the process, or in the age groups of screening to start this intervention younger and younger. So what is one thing that you can do? So I would, before we get into the questions, would just challenge everybody to start thinking about, you know, how could you start this process? What could you do to support SBIRT implementation, SBIRT services within your community, within your coalition maybe that you're a part of, agencies that you are in contact with? What's one thing that you could do? And as I mentioned earlier, if we write things down, we're more likely to do them. So I would encourage anyone that felt comfortable, you can certainly put that in the chat, or you can just make yourself a little note there at your desk or wherever you're sitting to just say, what is one thing that you could do? What would be the next step for you? So I did want to give a little time for questions. We have about 5 minutes left. I don't know, did we have any, Sean, do we have any questions already?
Yeah, absolutely. We have a few good questions. One question I'd like to start with, you talk a lot at the beginning about not needing to follow specific steps to conduct the brief negotiated interview, and to stick more with the spirit of motivational interviewing. could you give some counterexamples? Like, what would be not following that spirit? What would be something that you think wouldn't, because if I know what to avoid, I can easily get a better sense of what to do in that interview.
Sure, sure. No, that's a great question, Sean. I think, again, the steps are there to provide guidance. I wouldn't say that I wouldn't recommend, I do recommend following those steps. I think it's okay if we veer off. To your question, maybe what to avoid, I think, there are some specific things that we can avoid, slipping into the role of expert about a person's life. They've known them the longest, probably. And so really steering clear of trying to push or persuade people to make a change is seen probably getting away from that spirit of motivational interviewing. So for example, if we were to, give them reasons why they should make this change. Well, gosh, you've got diabetes, and, we just start making this list of reasons why a person could change. What often happens is that people then kind of in their own mind start coming up with all the reasons why that's not going to work or why that's not important to them. So really steering clear of that. It's a lot of, I think, if we keep in mind that seeking to understand instead of assuming we understand the person better than they do, that we know what's best for them. We certainly may be in a position where we can see things that maybe aren't great about their use. However, the more we push, there's a natural human response to push back. So if we're really going to adhere to that motivational interviewing style, it really is a lot of questions, a lot of reflective listening, being able to, again, meet the person where they're at, and really at the base of this is recognizing they have a right to self-determination. They're going to choose they have the power to choose, and ultimately they're going to be the ones that leave and are going to do what they're going to do, and they have a right to that. So really seeing that person as the expert of them, recognizing that they're going to find their own motivation. It's going to be way better than anything we come up with anyway. So I think those are some things to keep in mind. If some of the resources listed there, like the SBIRT.care, the SBIRT Oregon, there's actually some really good helpful hints and resources specifically around the brief intervention that I would definitely recommend or encourage folks to check out.
Moving on, do you think that is there a limit to how we're screening people? There's a great question here about, can we screen for adverse childhood experience at the same time as screening for SBIRT? And if we can do that, what would be sort of the best approach for implementing that?
Okay, no, wonderful question. I love where people are going with this. So yeah, I think sometimes that's a barrier, or sometimes people's hesitancy gets to, where do we draw the line on these screens? We can screen for mental health, we can screen for substance use, we can screen for trauma. I think, again, recognizing that there are multiple screens out there. SAMHSA has a really great website that actually lists those screens, different screens for different things. Trauma, or adverse childhood events, or what some people may have heard of as ACEs, I think there's great value in screening for that as well. And there are some screens out there that have some, I'm not as familiar with the exact screens. I think we can find the link there to the SAMHSA site that lists those. But there are some that have, that look at trauma, for sure, histories of trauma, that sort of thing, more as it manifests itself. As we know, trauma is a common factor in not only substance use later on in life, but also other mental health issues. So I think, as we start to look at depression, anxiety, post-traumatic stress, those kinds of disorders, there's definitely concrete, very good evidence-based screens that we can do for those symptoms, to identify those symptoms which may indicate a history of trauma or adverse childhood events. I do think, as agencies start to look at holistic care, the other thing I would encourage is that, sometimes we get to looking at that 1 hour intake, or when someone comes into treatment, we got to get all this stuff done right during that time, and it gets a little overwhelming. The one thing I have encouraged agencies to look at is, okay, does it make sense to get kind of the main bulk of what you need during that first session? It doesn't mean that you can't do that in subsequent or follow-up sessions that happen. So, for example, someone comes into an intake in a clinic, maybe that first session, we really determine these are the priorities of what we need to determine that's really going to have the most impact on the care that we're providing. And then in that second session, maybe we do some of the subsequent screening, try to kind of determine within our agency or, within our own policies what makes sense to be doing and how much time we have, staffing, all those things play into that implementation process. But I will try to find, I don't know, is that something, Sean, we could add in? I can get that link to those screens to you. Is that something that we could post somewhere or add?
Yeah, absolutely.
Okay.
There's a couple more questions that we'll probably have to take some of these offline. Though, let me ask this question now, if you have time, Christina.
Sure.
Are there any recommended resources for implementing SBIRT for more elderly communities, knowing that this is a population where alcohol and prescription medicine misuse are significant growing problems?
Absolutely. That's such a great question. And yes, again, we're seeing rates of substance use in elderly populations growing. The acknowledgement that this is causing issues, and again, as it relates to health, is huge. The impact of that. I'm not just to the very springing to my mind in thinking of specific resources around elderly, although I definitely could take a look at that. I think, just as we look at screens, they are validated up. There is no age limit on them. Sometimes there is a minimum age, so they're validated from 18 and above, that sort of thing. I think just again, as we open up this conversation, start creating environments where it's okay to talk about it, I think we may be able to identify this earlier, for those that are aging and in different settings. It absolutely makes sense to start asking these questions frequently. Again, universally, we ask this of everyone, explain why, and start having those conversations, because yeah, that's such a great point. It's we're definitely seeing a rise in rates and in the impact in that age group. So I will take a look at that as well and see if I can find any specifics around that.
That's great. That's great. With that said, we are just a couple minutes past the hour, so we should wrap up for today. I do want to thank everybody for calling in today. And of course, thank you so much, Christina, for another excellent webinar. Our next upcoming webinar will be just after the new year, that first full week. We have community readiness and organizational capacity. So sort of as we're thinking about different interventions that we want to implement into the community, what steps can we take to really assess where our community is? It's so important for considering the success of the project. So that's going to be on January 7th at 2 p.m. on Eastern Standard Time. And do, of course, email me, Sean Moore at cadca.org. If you have any questions or about notifications for upcoming webinars, or for any follow-up to this webinar. With that said, I think we can wrap up. We'll be following up shortly with a number of resources, including the slide deck for this webinar.
Thanks, everybody. Appreciate you being here.